right, welcome everyone, and thank you for joining us. We are quite excited to host this episode of the Journal Club webinar through the National Academies of Practice. Our mission here is to highlight the journal for the Academy, the Journal of Interprofessional Education and Practice, as well as our authors who are members in order to encourage scholarship and collaboration as we go forward. Today, we're very excited to have to present the Global Leadership in IPECP Research and Introduction to Co-Creation of Best Practices. I do want to give it back to Jess so we can have some instructions about what will happen in the webinar today.
Thank you. So basic webinar etiquette, everyone's seen this before, I'm sure, but we are recording and this will be available after the fact on the NAP YouTube. It is a live chat, so if you have any questions at all during the presentation, and please feel free to put them in the chat, and there's time dedicated for Q&A to address any questions. And then we do just ask that we remain muted while the presenters are speaking, so there's no background noise. And then I think everyone on here is already a member, but we do have the associate membership with the National Academies of Practice, which you can join at any time during the year. It does not require the nomination application process. It's just submitting an application. And we would love to love to have you join us. And please pass the word along to anyone you know who would be interested in joining the National Academies of Practice. And I'm just going to pass it back to Betsy.
Yes, so thank you again to our team of presenters. We are thrilled to have Dr. Hussein Khalili, Dr. John Gilbert, Dr. Jill Thistlethwaite, Dr. Sylvia Langlois, and I'm not sure other presenters here, but to present their article today. It is a work of IPR.global, and it will focus on framework for proceeding with research in interprofessional education and collaborative practice. And then I think Joan and Kim are going to introduce the rest of the authors.
Sure. So we're so delighted that our lead author is a member of NAP, and we also want to honor the other co-authors. And so happy to have you contribute to the scholarship in IPE and practice. We have Anthony Breitbart, Dr. Anthony Breitbart from St. Louis University. We have Gail Jensen, who's the Vice Provost for Learning and Assessment at Creighton University. Dr. Charlotte King is the Associate Professor Director from Health Sciences, Education and Research Commons at the University of Alberta. Dr. Devin Nickel is from the University of Nebraska Medical Center. And our own Andrea Feifel, who's our Associate Vice President of Interprofessional Practice and Education, Professor, Family of Community Medicine at Ohio State, and of course, a big anchor to our NAP family.
Dr. Khalili, I'm going to give it to you. They do have questions built in throughout, so we can have conversations as we go. Also post your questions in the chat. But thank you very much to our authors and presenters today.
Thank you, Dr. Blake, and thank you, the National Academies of Practice and the Journal Club Committee. We really appreciate that. So on behalf of our team, so we declare that there is no conflict of interest based on what is written on this slide. So thank you. So for this hour, we have three broad objectives for the session. So really our hope is that we can engage everyone in the conversation. It's going to be very informal conversation and discussions. We are here to learn from each and every one of you. As at the same time, we are happy to share some of our insights. So please feel free to utilize the chat and mic and to interrupt us at any moment. So I know it was mentioned, keep yourself muted, but please, at any moment, if you have any questions, come and please stop us. And also we have questions for the conversation and discussion. Back to the objectives. So three major objectives. One, we just want to make sure that we, with your help, can identify some of those theoretical and conceptual frameworks and research methodology and design that underpin IPECP. So we have some as an example, but it would be great to hear from each and every one of you. We want, as a team, as a whole, so we can reflect on, the application of theoretical framework, research methodology, and the design, when it comes to IPCP studies and research. And the last but not least, we want to engage you in the discussions to identify some of the priorities that you think is important for the IPCP research. And as was mentioned, this journal club is based on a paper that was published earlier in 2021. And that paper was based on workshops that the team presented at CAP conference in Indiana in 2019. So our work evolved, and we will discuss further about this. And also based on the information we received, our paper also received the WHO recognition. Some and others, I know, I can't recall the exact certificate that we got. It was a paper that was cited and also got the recognitions from the WHO in 2022, I believe. And thanks for the link in the chat. So I'm going to go through maybe a few slides, and then the team will join, and we will have further conversation and discussion as we go through. So the first slide that you can see here is, why theory? Based on a number of different reports, as well as systematic review and meta-analysis that have been done in the past even decades or so, one of the areas that have been criticized or commented that we receive for IPCP research is that, our research is not underpinned by the theoretical frameworks or theory and others that help further generalize and also further guide future research and the application of the results. So in addition to methodology that needs to be improved, including theoretical frameworks is being considered as a core area for further improvement in IPCP research. And for sure, all of you are aware of the importance of theory when it comes to research. Just imagine, when you want to travel, so it's very important. You might have some ideas where you want to go. I'm here in North Carolina. If you want to go to Florida, in my mind, I can come up with some ideas. And also, you can look into the literatures or Google. Let's say, since we're talking about travel, looking into Google here, there, or an app on the phone, and get some ideas. So then, as a next step, you really need to plan further and see, okay, if I go from, for example, this way is going to be 2 hours, longer. If I go from that way, it's a mountain. If I, all those. So you do your plan in literature review. At the end, you need to connect all those, variables in order to identify what would be your best approach to go. So that would be kind of conceptual frameworks. You connect some of the concepts that are relevant to your study, those variables, and kind of theorize, your way of doing. However, sometimes if you have GPS, then you can put where you are at, where you want to go, even if you want to identify exactly what time you want to arrive. You could include all those, and then it would come up with a kind of ready-made map that makes your life and everyone's life easier because, it gives you all the guidance. So theoretical framework is more like, ready-made map that you do your literature review, you do your analysis and review of theories out there that really help you to better connect all the variables, concepts, and construct that you look. So again, this is just hopefully gives you some ideas why theory is important. Theory would give conceptual, or give you framework. I don't want to use conceptual here because it's too different in the type that we're talking. Or give you frameworks for understanding of the phenomena that you are going to do your study on, and also help to hypothesize, help to better design your methodology, and when it comes to results and others, really guide the way that you can interpret the data in order to make some significant improvement in the knowledge area. In other words, when we talk about research, we say we need to remain open-minded. Even in qualitative research, we need to remain open-minded, but not empty-handed. It still is good to utilize what is out there and how the concepts and relationship being defined, and your research could either support those relationships or might come with new ideas, or completely, I don't want to say reject, at least you might come up with an alternative way of how things being related in real world. I'm just stopping and asking the team if you want to add anything to the theory component before moving. If not, go to the next slide. Thanks. So here are a few examples that we are, we know, we are familiar with those. Interprofessional socialization framework, dual identity. I happen to be the lead author and researcher in that area. We have a number of other theory that being utilized in interprofessional education and collaborative practice. Situated learning, adult learning, contact theory, system theory. There are lots of great applications, and I'm sure as we start discussion, colleagues can share their perspective and utilization of some of these theory. And please use the chat. And if you are using any other theory or theoretical frameworks that's helping you in your research, IPCP research, please share. Use the chat and share. And then when we get to the discussion, you can also use them. Next slide, please.
So yeah, hi. Good morning from Australia. Good evening where you are, most of you. So these are just a list of some of the research methodologies that we use in this field. It's not exhaustive. It's interesting as you read journals to see new methodologies coming into the field as well. And I'll just say that my background is as a medical doctor. So when I went through university, pretty much all we learned about research was randomized controlled trials and a very positivistic framework. And it wasn't until later in my career when I got more engaged in education and around communication that I realized there were other fields and other methodologies. So sometimes we need to open our minds to a richer area of tools that we can use and just read a lot around these to see what are the best methodologies for answering the questions that we have. I'll also say that there is often a blurring of lines between what is research and what is evaluation in our field. So particularly in papers that are more specifically around interprofessional education, a large proportion of papers that I review are evaluation and typically of small studies from one institution. These have a place, but the time has come, and this is what the paper and the discussion document that we'll mention later are advocating for, is that we need to move beyond these narrow questions and look more broadly at what the influence of the different types of interprofessional education are and what that means for collaborative practice. And we're an interesting and rich field because we're looking at education and we're also looking at what happens in practice. And some of the practice-based research is absolutely fascinating. So I do see certainly people from my own field of medicine still are stuck within this paradigm where we really need to do controlled trials, who will apologize for the fact that they're doing work without a control. But that's not important. It depends what your question is and your methodology and whether it's robust. So you can see the very commonly used quantitative tools there. And some of the things that we think about in terms of quantitative work, such as objectivity. The qualitative is, I'm biased now, I've moved very much from quantitative to qualitative over my lifetime. More of an understanding. It has got a reputation in that very scientific medical field that qualitative is somehow not as good, not as rigorous, not as important. And I think we're really challenging that and producing some wonderful work. So qualitative is not easier. I think that's important to say. So lots of different methods within qualitative research, lots of different theories that can be applied to that. And we're looking at trustworthiness and authenticity as a marker of quality. And we welcome the fact that it's subjective. And that's part of what we're looking at. And very much that idea of the lived experience as something, particularly in health services research, that we're finding out what's that experience of people working in teams or having care through team-based and collaborative practice. And then, of course, mixed methods bring those two together. So lots of different ways we can do this. The big message is quality, rationale, framework, why you're using the methodology that you are, underpinning that by a good rationale, having the right method for the right question, and then considering the trustworthiness or reliability of your results depending on your paradigm.
Thank you, Joe. John, do you want to lead this set of questions?
Yeah, well, let me just reflect a minute on what Jill said, because I have to admit I was an empiricist for most of my life because I worked in acoustics, and it's very empirical. But when I was introduced to IPE more than 40 years ago, it was clear to me that asking an answer to the null hypothesis was not going to solve some of the issues that you could see in practice. So I do think that the advantages of both quantitative and qualitative, as demonstrated in kind of a multi-approach, is really important to understand the truth and veracity of the definition. So I hear over and over again people say IPE as though that was one thing, and I am constantly guided by the definition. I think learning with, from, and about for the purposes of collaboration to improve the quality of care kind of covers the universe. So I was, I think, interested when we really started to see the emergence of research that a lot of it at that time, and still this occurs, is about the students like it, and inevitably they say, we'd love it, just give us a lot more of it. So we know that there's a huge kind of positive amongst our students and, in fact, our practice colleagues for trying to work together, because you can see the obvious results in terms of the quality of care. So in terms of the future research, we have lots and lots and lots of stuff now that tells us that they like to, that students and practitioners like to do this. I don't think we need any more, but you can disagree with me if you like. I don't want to read another article that says, oh, I ran the ripples. However good it happens to be, I don't want to see it again. There are some, for me, really interesting questions, but they're longitudinal questions. I want to know down the pike, 5 years after approach has been made to get students to learn with, from, and about each other to improve collaboration, that 5 years down the pike, those students are still doing what it was that they learned and practiced when they were pre-licensed. And we all know that longitudinal studies are very hard to fund. And that's really a shame, because we really do need longitudinal studies. I would like to know what evaluation metrics are best for longitudinal studies. And I think that certainly over the last 10 years, I don't think for much longer than that, we have seen the development of some very interesting evaluation studies for what I would call cross-sectional studies. But I think that we need to know that we can tell health and social care administrators, and of course, people at top universities, colleges, institutes, that actually this is a darn good way to make system change. So the top priority for me at the moment is, how do we do the longitudinal study? And there are lots of gaps and emerging trends in healthcare, as we well know. Healthcare is an ever-changing roundabout. This year it'll be one thing, next year it'll be another thing, and who knows, we'll be back at lean before we know it. And so the answer to the first question, my answer to the first question is, we've got to be able to see what's happening downstream. For me, it's really important for societal change. How can we collaborate to establish research agendas? Well, that's why we have IPR.G, and within our own countries, there are mechanisms which I think are probably designed to foster that kind of collaboration. So Sylvia, if I might speak on behalf of Canada, the Canadian Institutes for Health Research absolutely insists that any research that's done now is multidisciplinary, or interdisciplinary, but usually multidisciplinary. And that does bring people together from outside of traditional healthcare. We need the anthropologist, we need the sociologist, we need psychology, we need political economy, and we need economics. We need those views of what we do to ensure that what we are doing, makes intellectual sense in some sense. And I think that you were very fortunate in the United States. We admire what happened with Macy and with the money that was put into the National Center, because it has done a huge amount of good. And it does address this issue of collaboration. Much of what is kind of appearing in Nexus, I think, they're wonderful examples of collaboration, just a survey that was done last year. So it just, I think that we could talk more about collaboration across borders. That's why we have the biannual meeting between the United States and Canada. And I think that it's important to recognize that there are many language and cultural differences when we move to other continents, other countries, where it's not quite so self-evident that the English-speaking world has got it right. Okay, that's it. Thanks.
Thank you, John. So let's open up the conversation. So I think you did a great job in talking about some of the components relevant to the questions that we have here. The first questions that we have on the screen for everyone, please use my chat and share your thought. What should be the top priorities for future research in the field of international collaboration, including education and practice, considering current gaps and emerging trends in healthcare? Who wants to start?
I think Joan might have a question, but one of the things that we always see as a gap is the gap in the impact on health outcomes. So we always see, as Dr. Gilbert talked about, the Ripple study, which, for 10 years we've been told not to do. But beyond the attitudes of our students, how do we move forward to get that data for that further impact on health outcomes? How do we move to that practice change behavior and find that information? Jill?
You're muted, Jill.
Someone has to do that. You have to say that at least once in a meeting. Yeah, I think this is, this is the holy grail, isn't it? Because we're still kind of thinking of Kirkpatrick. What's the impact on consumers? What's the impact on outcomes? And I think the issues here are at what point you look at education to influence outcomes. So education at pre-licensure, first and second year, is not going to, you're not going to be able to show there's a direct link between what happens there and patient outcomes. It's just, and we don't actually, no one ever asks that question about medical education. It's what we do in medical education, improving patient outcomes, but it seems often that people ask these questions of interprofessional education, that they're not asking of their disciplinary education. So, it's a very, and that's been going on for such a long time because people have pushed back against what we do. So I think this issue of patient outcomes is really interesting, how we do that across all the education that we do. And it's much more likely to be education in those last few years before licensure and then into the first years of practice. What are we doing there to build on what they've learned to show that there are outcomes, knowing that the outcomes are likely to be related to team-based care and not individuals. Because the other issue is that often we're looking at, and when we assess people's knowledge in healthcare, we're usually looking at the individual and not taking into account that there's a team approach. So I think this is something we're grappling with all the time. And it would be really good to have some teams looking at this, how we do it.
Great comments. Oh, sorry, John, do you want to go ahead?
Okay, I just want to respond. Arvi has posted in the chat. I mean, identify, address organization, cultural, systemic barriers, repeat effect. Absolutely, I think we're trying to do that. And I've even written a long time ago about what those are. But the research priorities of acute care institutions are very interesting. Certainly in the institutions I'm associated with, it's all about trials, right? Why? Because trials bring in a lot of money, and it's very difficult to, kind of get policies at the highest level in an acute care setting to say, oh, education is important because we spend 33% of our budget on it. It's really focused on research, and the research is of the kind that Jill originally described. It's quantitative, that's not where we are now. So the good points are, and we're really, I hope that I'm pronouncing your name the correct way. And reimbursement models, the reimbursement models for physicians in primary healthcare, Jill, you could say a word about that. These are tough hurdles, because in Canada, we have now a huge initiative around, yet again, primary healthcare, and we're talking about teams, community teams, etc. But I don't know that we've gotten the reimbursement model correct to make it truly effective for all members of those teams. So we need to look at that particular piece. How do reimbursement models really affect our attempts to be collaborative? Because at least in our system in Canada, it's throughput. The physician has to see, X number of patients every day in order to fund the practice. So that's a very interesting observation. Thank you for it. That's it. Thanks.
Can I follow up on that as well? And this is also a plea to people publishing. There is sometimes when you're reading a paper, the authors are expecting to understand the context of the country in terms of how the health system runs, funding models, all of these things. And it can be very hard to make sense of the findings if you don't understand the context. So you always never assume that your readership, which will be global, will understand those factors, and always include something about the context, because our funding models vary tremendously. And as someone who came through the National Health Service in the UK and is now in Australia, it's the pressures, the factors, the culture, all are different and result in different enablers and barriers. So please don't assume that we all understand everybody's national services.
Yeah, thanks for your comments, John and Jill, for that additional clarification as well. I'm looking at, we skipped over at Tony's comment on it being the research needs to be wider, multiple contexts, multiple institutions, and deeper longitudinal. And so we chatted a bit about, or John did as well, about the need for something that is more longitudinal for help us to understand. I might add, and I'd be curious as to what the group thinks here, I might add the need to understand how we conceptualize teams. So we can say, well, maybe that's clear, but so often, and maybe it reflects just some work that we've just done and published on as well. So often when we think about teams, we picture these co-located teams and the dynamics of those teams and what the barriers are to working together, sitting in a hospital setting, or typically be hospital where they're co-located. And yet so much of our healthcare extends beyond the traditional hospital setting, and how is it that we understand how teams work together? So we can look a bit towards Andres Zrikis and Scott Reeves' work on the Interpack model of the different forms of teamwork, for example. So whether it's teamwork or collaboration or coordination or networking, which become a bit looser, common goals, but a bit looser as we work through in different systems, and thinking about what does that mean for collaboration and teamwork? How do we conceptualize, and how do we move beyond, like, do we think system, broader system? What's important for the healthcare system, given the different contexts, maybe institutional, there's so many different factors, but what's important for the system, knowing that the people we serve move through the system. They're not just sitting in a hospital setting, they're moving into community clinic settings, and they maybe moving into areas that are looser and yet still require the team, the all of the expertise of the team to be fully engaged. So I think a little bit about where we where some of our conceptualization is, and what we need for the benefit of the system. So those are just things that I've been thinking about, and I'd be curious if others are also thinking about that.
And then Joan, if you'd like to ask your question.
Sure. So I'm wondering if, considering through the lens of the leadership of our researchers, so some of us are farther along the continuum than others with regard to the IPECP leadership, research models and scholarship. But I'm wondering, how can we leverage the individuals and organizations effectively to contribute to advancing that, but also ensuring inclusivity and equity? I think that's such an important part of the future of our workforce. And so I'm wondering how we can say, let's, put that as a priority, or how are people identifying that as a priority, and how are the leaders in this space identifying that as a priority? And also, just as an aside, I too am now having heart palpitations with the number of AI comments in the chat, because just in the past 2 weeks, I feel like my world has blown up with AI. So, but I'd welcome our experts to share their thoughts on making the research priority to include diversity, equity, inclusivity, that kind of thing.
Thank you. Very good timing. So I'm not sure if you have had the chance or you have received any information about the recent report that International Research Global published just in a matter of months. So it was January. It was also on the AIC website. I'm not sure if NAP included in the news time as well. IPEC and others, they added into their website as well. Israel is talking about transformative power of DEI and social justice related to IPECP. Of course, your comment is more towards research, and that could be a next step as well. I think that's very relevant. And also, when we go to the next few slides, you will see that we at least in the reports that we published in 2019 and then updated in 2021, we were focusing exactly what John was saying, that the team should be inclusive of not just the traditional healthcare people, also non-traditional, from education to economy to even police and many others. Anyone who directly or indirectly connect and improve the quality of health and healthcare should be included. A great point. Thank you. And I'm just pausing to hear from the rest of the team. And I have the link to the paper later in this slide. So, and also it's on the website. So it's publicly available for the DEI paper that we just mentioned. Thank you. Any last comment on this slide? So still we have, another set of questions that we will share, but let's just see if there is any last comment and related to any of these questions here. Otherwise, in the next slides, we'll recap what was some of the priorities that we came up. Just if you don't mind, if you can move to the next slide. So again, thanks to the great conversations and based on our missions and also mentioned earlier, in 2019, we also published guidance on global interprofessional education and collaborative practice research as a discussion paper. And if you move to the next slide, so you will see, and also we updated, at the time of COVID, some of these priorities. And the next slides, identify the top 3 priorities that we identified that we think is still very relevant based on the conversation that we had today as well. One area of the priorities, at least from the perspective of interprofessional research at Global, is how we can advance the science and the scholarship of IPECP in general, because it still is a new field. So we need to build on the science component and knowledge component to advance IPECP. Second, the complexity issue. As Jill mentioned, John and everyone, healthcare is complex. So it's not an easy thing to just connect in a one IPE event to advancements of patient outcome and outcomes. And also, we know based on the WHO call to actions that John was leading that, as well as the IPEC competencies for students, for example, or in education, IPE, or client is a student, or our clients are students. And if we make them collaborative practice ready, really we achieve at least a major component of the impact for the IPE. When it comes to the practice, this is how those graduates and those who are going to practice really work as a change agent to bring further impact on the healthcare system. So any design, any research to connect and to identify and address those complexity would be a priorities. And the third is the continuum. So IPE should not be seen as isolation, the same as IPECP. These are connected, and even the research component. So how we can, show the impact from education to practice to health outcome to quantifiable aim, as well as the research outcome as well. So those are the top priority that covers the majority of the conversation that we have here as well. So again, I'm going to pause and see any reaction from the participants, the team, as well as from the co-presenters here. Yes, John.
Yeah, so I don't know. I worry that the development of the definition for IPE actually goes all the way to collaborative practice, and it's painful for me to see IPECP because it makes the definition really wonky, and I don't know what to do about it. But I do know that our research has to agree on the terminology that we agree on with respect to interprofessional education. And so in our research priorities, I reviewed 2 papers this week, and honestly, it was like apples and oranges. And both sets of authors claimed they were talking about interprofessional education, and they clearly weren't. So if these are our research priorities, can we please have as a subtext that they'll all use at least something approaching the same lexicon? Because otherwise, I don't know how to make a value judgment. There are really good papers that really do understand what the words mean. But there are a lot of folks out there who pretend they're Humpty Dumpty, and they just give the meaning to any kind of word that they put up there. So the priorities I agree with the priorities, and we've been through that, but I do really make a plea that people learn the lexicon that we worked on, Hossein, learn that there is a meaning to the words that are used, and they need to use those words. Otherwise, I'll just be constantly saying, don't publish this. Okay, that's it. Thanks.
Thank you, John. And the lexicon, I think, NAP has its own lexicon, is more depth and inclusive of all the academies that we have. And we published the lexicon in 2019 as part of that publication that was in the previous slide. I think it's time to potentially have another look and republish and update the lexicon as well, for sure. Thank you. Jill. You're muted.
My dog was barking, so I muted myself. Yeah, I agree with John, and I mean, I think it's also collaborative practice is even more tricky, because I just reviewed a paper looking at collaborative practice, which didn't define it, and then we're asking people their perspectives on collaborative practice, and I had no idea if everybody who was being asked saw, defined collaborative practice in the same way, because it's, we've now got at the moment in Australia and elsewhere, the other notion of integrated care, which has a lot of commonalities, but is not, is again, any jurisdiction that's doing integrated care is doing that in a different way. So, I mean, I don't mind if people have different definitions as long as they tell us what they are. And that they have a, everything should be right. This is our definition. So this is when we talk about this in the rest of this paper or the rest of this research, this is what we're talking about. Because the words just become, anything could be hung on them, and then we really don't know where we're going. And I'll try to remember. I'm going to stay on not muted, I think.
No, thanks, Jill.
I need to learn.
Yeah. The beauty of academia is that we are always looking to advance and develop on others, and people as soon as they look into literatures, come up with new ideas, and they publish, and sometimes don't want to utilize the same terms and come up with new terms and others that sometimes could be confusing, for sure. So yeah, go ahead.
The other thing I'll say around impact on top of that, which is even harder, is return on investment. And we're seeing a few papers coming through in the health professional education literature now, which are trying to look at a monetary value, because that's what people are going to be asking for as well. Well, what's, this costs so much, what are we getting for it? So I think, eventually we'll have to start thinking about that as well as impact.
Well, we started doing it. We started 15 years ago in Canada trying to do an ROI, but we didn't even know how much it costs to train a medical student or a nursing student, and we still have no knowledge of what that costs. So doing an ROI for impact is really, really hard. I agree. It's just really hard. Sorry, Sylvia. I know you were.
Yeah, sorry, Sylvia.
Yeah, not at all. My comment was just in terms of research priorities, and I think you've mentioned some good things that are very much system and understanding system. But in terms of research priorities, I think we sit in a really wonderful spot now. And yes, it's challenging. It's a difficult spot, and as all research would be, but we have a good foundation. And as John said, we've got all of that early work that, we want to move beyond the ripples and all of those kinds of things. Like, we've got some really good early work, and now's the time to really move forward and to advance the field. And I think through that advancement, it can only happen through collaboration. So it's identifying what these research priorities are, understanding our context and what works across different contexts and different types of teams, et cetera, et cetera. But it's an opportunity to really, I kind of describe it as linking arms and collaborating and beginning to really work together to advance the field. And I think that's what the exciting part is. And I feel that there's a bit of a shift in the system that allows for more of that collaboration to happen and for a broader understanding of the field. So this kind of a document or this discussion paper to me are really important in being able to identify where we need to go and how we move forward. And that takes us to some more discussion questions in the last 13 minutes we have left here. And I will ask you, in terms of research, and we'd really like to hear more from you. And I know it's late for many of you, but it really is an exciting time to engage. And so think about what are some of those key challenges that are faced by you as researchers when you're studying the field, and how can these challenges be addressed to promote more comprehensive and insightful research? So what is it that the field needs, and how do we work towards advancing? And Tony, I see a couple of comments from you, needing to collaborate together as stewards of the field and avoiding the collaborative silos, 100%. And those of us who work in academia, we know how important it is for our own institutions to, be the greatest institutions nationally or whatever. And I have fought against those kinds of things, and I'd much rather advance the field than I would my own institution. So I agree that we have to be able to get over institutions, countries, associations, everything, and really begin working together more. And Tony, also your comment about sharing language and priorities and being open to collaboration across borders. Tony, do you want to speak to those at all? A little bit more?
Yeah, I think any field of research always has a tendency to be get a little competitive. That's just human nature, right? And I think we have to kind of sometimes check our egos at the door and find those shared values to be able to work together, because there's a lot of people pushing against what we're trying to do around interprofessional collaboration. And if we can't join together and get on the same page and be moving around some common priorities, we're going to lose number one, lose a lot of credibility with the detractors. And number two, we'll never get the traction that we need to really make a lasting change in the system.
Yeah, Tony, thank you. And in fact, you've addressed what some of these key challenges are as well. So excellent, John.
Yeah, if I just, Tony kind of touches on this, but when I go to other countries, and I'm sure you do, I'm always concerned for my colleagues because their fear is everything has to be in English. And so it's very hard for them to publish the good work that they're doing because they don't feel that they have the language skills. And I know Jill must have had to cope with this when she was editor of the journal. I think that there is I know there's some wonderful work going on in countries who are members of our federation, right? IPR Global. I work with a group in the Philippines, in Manila, who actually do all of their work with community leaders. And it's very interesting that they go in and they don't say, this is what we're going to do for you. They ask what it is that they can do for their community, and the community then comes back with some absolutely amazing ideas. And I say, well, we should publish this. And they say, well, we don't feel comfortable. And then we don't feel comfortable in English. And I say, well, I can help you do that. But there's no national language journal that they can put their work in so that the diaspora of that work could get on with doing it in the Philippines. And that's just one example, because I work in India as well. So the language issue around publication, I think is a big problem, Jill, but you may have a
I just actually put that comment in as you started to speak. So we were thinking of exactly the same thing. And I think this is a problem. And the other thing is, since COVID, there's been a huge upsurge in the number of papers being submitted around the place that are reviews, scoping reviews, systematic reviews, narrative reviews, whatever. And all of them, without exception, as an exclusion, is papers not published in English.
Mm-hmm. Mm-hmm.
And we're missing so much because of that, and having an understanding of different countries and how they work and their systems, particularly in this area at the moment where workforce is a major problem, and some countries are struggling with their healthcare workforce. And those countries that have the luxury of being able to have interprofessional teams of 5, 6, 7, 8 different professions working together that's not happening in some countries. So, you know, what does interprofessional collaboration look like when there's a reduced workforce? So I think I don't know what the answer to it is, because I could get along in one other language just about, but not probably in an academic way. So you know, that comes back to the inclusion piece, doesn't it? And I don't know that ChatGPT translates for us accurately.
Yeah, I think that's really important. And, you know, also looking at global research is we make the assumption that, you know, that English is always dominant, and what happens in the English countries has that dominance. And yet there is such amazing work happening in so many different contexts, and developing those collaborations across international contexts is so important. So 6 minutes left. Hossein, do we have time for the next question, just to think about theoretical frameworks for a bit? Okay, so next question, think about how can theoretical frameworks from disciplines such as sociology, psychology, education be applied to advance our understanding of interprofessional collaboration in healthcare settings? Who's working at the work that you're doing? Who's working in some of those other fields or thinking about these other fields? And sorry, I'm on with the presenters here.
Yeah, at St. Louis University, we have taken our entry-level undergraduate IPE courses and actually align them with the university core. So one of the things we need to do is we need to be able to embed some of the university core learning outcomes around better sense of identity, global interdependence, social justice, health equity, even as far as one of them is a writing intensive course. So actually we have a course where our students write to 7 different audiences throughout the course. The public, policymakers, an academic, lay, for a lay audience with low health literacy. And I think that's really helped open up our eyes, because we always kind of start as health professionals as a baseline when we think of our students or our audience, and it's really forced us to look deeper into the own personal identities of all of our students and all of our stakeholders, and it's really created a richer course.
Hey, great. Thanks, Tony. Thanks for sharing that. I think it's a great example of drawing in and having a lens for others as well in the system. And you're right, we do make assumptions.
Thank you, Sylvia, and thank you, the team. So in the interest of time, so I think there are a couple of 2 more slides from us and potentially 1 from the NAP as well. So if you're okay, Sylvia, we can move ahead. So thanks again. So this is a snapshot of some of the recent publication and recent activities that Social Research Global put out there. So from the global guidance submissions, the proposed lexicon, we have published in the paper on healthcare resiliency, and they have been very well received. Almost all of these have been published in paper format as well, journal format. We have the global IP situational analysis that was published in 2022. It's a very good snapshot of where we are at in a global level when it comes to interventional education, not practice, just education. And then also last year, we published the IPCP post-COVID era. So really great discussions on digital or virtual learning, telehealth, and some other component when it comes post-COVID. And also mentions very recently, just last month, we published a transformative power of inclusion, diversity, equity, accessibility, and social justice in IPCP. A number of our book has been published in collaboration with different regional networks or IP.G as well. So, and also we are very pleased, and this journal club is based on the MOU that we have with the National Academies of Practice. So again, we are very excited about this. We have a MOU with the Canadian Institutional Health Collaborative. And we have a blog and a scholar spotlight for anyone to highlight themselves or colleagues and any events, any papers that you want to publish or post it. And Tony is our person. So thanks, Tony, for handling all those. So please feel free to submit. And also we have global awards. So IPR, the global awards that the applications for 2025. So will be published or will be released by April. So please watch for those one. And again, our membership is free of charge, and we're always looking for people who are interested in IPCP like yourself. So please send me an email, and also we have email address in the next slides that you can contact us. Go to the next slide. I think we may not have any time for people to use the mic, but please use the chat in a few words or sentence. Just tell us how did the session is going to help you with your IPCP research work and others, and then how you're going to move forward. Please, do that one. And as we're going to the next slide, so we're watching to the chat just to make sure so any comments that you have. And here is the email that we have, ipresearch.global@gmail.com. And I think that should be it. Again, thanks on behalf of the team. I would like to thank every one of you joining, and also for the NAP to give us this opportunity, and also want to thank the team here for taking the time and being part of the presentation. I appreciate that. Back to the NAP team.
Thank you very, very much. That was a great conversations from our international leaders in IPE, a lot of thought-provoking discussion on where we can go forward within our institutions and beyond. So this was really a great exploration beyond the journal for what we can do with interprofessional education and collaborative practice. We do want to invite you to our next Journal Club webinars, May 8th. We will be featuring interprofessional education clinics and improved outcomes for primary care patients with diabetes. And then August 22nd, we will highlight building interprofessional team competence through online synchronous simulation of palliative care scenarios. And this session would not be complete without thanking Arvi Vatente as well. He's my co-chair who's been under the weather this week and would have loved to have joined us more to speak, but at least joined us in the chat today. But thank you again to our presenters, to the authors, to the collaborative team, and to those of you who joined us.